It was there, but now it's not.
No, now. I'm trying to. What's the problem? It's okay now?
No, not yet.
No,
I can't
not
see it.
yet. Okay, so that's the problem. Sorry for this technical problem, but I try to just now. No, I'm sharing my screen. I shared my screen with you.
Yeah, it's clear, Doctor. Now.
It's okay?
Yep.
Can I put this? It's okay now?
Yep,
Can we
still
start?
clear. Yeah.
Yeah, okay. Good morning, good afternoon, good evening for everybody. I'm very happy to be invited by MIFON for this monthly webinar. We are going to speak about radiation protection in interventional radiology. I know that most of medical physicists like radiotherapy topics, but we have something to talk about in diagnostic radiology and especially in interventional radiology. Let's first present myself. I'm Yehia Lahfi. I'm from Atomic Energy Commission of Syria. I'm the head of Health Physics Division. I'm a diagnostic medical physicist, basically coming from the biomedical engineering background. So I'm interested in image processing, in diagnostic radiology and interventional radiology. Then I moved to the field of dose measurement and radiation protection. The topics for today will be focused on the radiation protection in interventional radiology for patients and staff and public. So we will cover several points regarding the objective of radiation protection IR, dosimetric quantities and factors affecting patient dose, affecting staff dose, and how to optimize these doses, the new techniques in this field. Also, we will discuss at the end the risk management and conclusion and future consideration. So I will move quickly for the general introduction. We will, first of all, for all interventional radiologists, interventional radiology have been increasing significantly due to emphasis in minimally invasive techniques. We count today about from 10 to 20 million interventional radiology procedure per year, and the statistics for US is about 5 million. We have 10 of thousands of interventional radiologists supported by hundreds of thousands of technologists, nurses, and radiographers and other staff all over the world. So there is a huge number of people who are working in this interesting diagnostic radiology. Why there is a fast increase in IR procedure? In fact, the growing demand for minimally invasive surgery, the expansion in use of image-guided biopsies and catheter-based intervention, and the rising prevalence of cardiovascular diseases, cancer, and other chronic conditions have led to a huge number of patients who are treated, diagnostic, and treated in interventional radiology procedure. First, of course, you may agree with me that the first interventional procedure was concentrated in vascular. Now we have a variety of medical problems that we can solve in interventional radiology. And for this reason, we have several types of interventional radiology systems, starting for undercush fluoroscopy systems, which is the old one, and then the C-arm biplane and one-plane IR. We have a mobile C-arm, and now we have is a CT fluoroscopy. Why there is an importance of radiation protection in interventional radiology? In fact, as IR uses the X-rays to visualize anatomy and guide minimally invasive treatments, The IR procedure become more common and more complex. So patient and staff radiation exposure has been increasing. This increasing necessitating strengthened radiation safety protocols against its both short-term and long-term effects. As you know that there is the deterministic effects of harmful deterministic effects of radiation can be appeared in interventional radiology for several reasons. Unoptimized IR procedure may involve high patient skin doses and lead to tissue reactions, and for the staff also high staff eye lenses doses can lead to cataract in this circumstances, and there is the increase the probability of cancer. This is several biological effects of ionizing radiation, which we all of us perhaps have a strong idea about that. Deterministic effects, which change in the tissue reaction for the ICRP 1.3, occur when radiation doses exceed certain thresholds. So toxic effects are random and have no threshold, and they include long-term effects such as cancer. The acute effects of radiation, ionizing radiation, may include skin injuries, often manifesting weeks or months post-procedure if exposure is excessive. However, the long-term effects, which involve a potential increase in the incidence of cancer, may appear further with the time in organs with higher radiation sensitivity, like the thyroid, lungs, and bone marrow. The deterministic effects appear after passing a certain threshold of doses. For cataract, 500 millisieverts. For sterility, for example, 150 millisieverts. However, for stochastic effect, the probability of occurrence, these stochastic effects increase with the doses. The ICRP has put some thresholded for thresholded for dose limit for occupational exposure and general public. As you know, that 1 millisievert for general public for 20 millisievert per year for occupational exposure. This is as an effective dose. However, for the deterministic effects, the equivalent dose to eye lens was 20 millisievert, and for skin 500, and for head and feet 500 millisieverts. The objective of radiation protection in general is to achieve appropriate level of protection for people and environment against the deterministic effects of radiation exposure without limiting the desirable human actions that may be associated with such exposure. So we are primarily focused on the protection of a human health against tissue effects and also against cancer. What is the principal radiation protection? We have three main axes which radiation protection resides: the justification of any activity necessitating the radiation exposure. So we have to justify any use of ionizing radiation, and such that the benefits will be greater than the probable harmful effects. To do this in good manner, we have to optimize our procedure. This is the second principle, and there is the dose limits, which are this is the threshold for the deterministic effects, as we said previously. The radiation protection practical principles are the time, shielding, and distances, as you know. So we have to do the smallest time possible with the longer distance from the radiation sources, and we have to use the shields between the radiation, between the sources and us. Why radiation protection in interventional radiology becomes important nowadays? We have seen an increasing number of clinicals which are not adequately trained in radiation safety and radiobiology, microradiobiology. And many patients are not being consulted on the major and radiation risks nor followed up for the onset of injury, when radiation doses from difficult procedure may lead to injury. Patients, especially younger ones, may face an increased risk of future cancer. So the correct use of equipment is essential in these cases. We are focused on the radiation protection of the staff as they are working with the radiation all of their time of career, patients, and also people. And we have to achieve the radiation protection goals in IR by understanding our IR system, optimizing the patient dose, and optimizing the staff doses. Let's move to the radiation dosimetric quantities in interventional radiology, which appear on our screen during our works. So just for remembering that the entrance, we have 4 major dosimetric quantities. The first one is the entrance surface doses, ESD, which is measured in milligray and is measured on the surface of the patient or phantom, and it includes a contribution from photons scattered back from deeper tissue. The second quantity is the dose area product or Kerma area product, which is defined as the dose in air in a plane integrated over the area of interest. This quantity is useful for tracking cumulative radiation exposure across different parts of the body. And the third one is the reference air Kerma, which is measured at a point in the space along the central X-ray beam, 15 centimeter back from the isocenter towards the X-ray tube, which called the patient entrance reference point. It's a rough approximation of skin doses, but it's not include beam repositioning, backscatter, or attenuation of the table, and it can be used to estimate the peak skin doses. This peak skin doses is the first quantity, which is the accumulated absorbed dose to height irradiated area of the skin. Here, with this one, we track this one to evaluate any injuries related to the radiation in the patient skin. All these quantities, however, some of them are appeared on our screens. Here we can see the exposure doses in milligray and in centigrade. This is the DAB, this is the Kerma at the reference point. And this appear also at the patient report of doses. We can determine the doses of ASD by using either TLD or OSLD dosimeter on patient or in fact on phantom, or we can use the gaphachromic film, which provide a visual indicator of beam overlap and skin sparing. In fact, all IR system is equipped nowadays with a dose monitoring technology such as DAP meter, and also in the new one, the real-time fluoroscopic dose monitoring system. This is the interventional radiology procedure doses, typical entrance skin doses for some procedure starting from 30 milligray up to for complex procedures up to 2 gray. So in order to obtain the radiation protection, as we said, we have to understand our interventional radiology machine. First of all, the machines has been, or the system has been evaluated over the time, starting from this old machine. Nowadays, we have a complicated machines with a flat panel detectors and huge X-ray tubes, and provide some additional layers of monitoring of the images and image processing. So we have a complex system in our cath labs and interventional radiology departments. The WHO IR recommended technical specification of interventional radiology system, which should have at least, or not at least, we should have all these recommendation. Nowadays, all our interventional radiology system have most of them. So we have the last image hold, we have the flexibility of automatic exposure control, the temporal filtering, the depth meters, and automatic injector, and so on. Some additional recommendation like road mapping, which use of a reference image on which the current image is overlaid. So we can see the DSA, for example, without the road mapping, and this in this image with the road mapping. We have a very clear images in this type of options. Also, we have a region of interest. We can filters region of interest fluoroscopy, which present a low noise image in the center, surrounded by a low dose noisy region. So we can concentrate on the diagnostically image region for the doctors without exposing all the surrounding area with a huge doses. And this will lead to reduce the patient doses. Also, we can see the computer interface for dosimetry confirmation. This is a new system which presents a real-time color pictorial radiation monitoring during the coronary angiography. So we can have an estimation of the patient's skin dose during the procedure. This can be useful for some complex interventions. We have other requirements such as collimation without radiation with the last image hold. Also, the patient positioning without the radiation, which can present a graphical display showing the central beam, for example, location and each of field on the last image hold. Also, we can add automatic beam filtration. In fact, these options are now in the majority of systems are available, and with time, really every day we can see and new options that serve to reduce the dose for patient and present a clear and noiseless image during the interventional radiology. Let's have a look on the room requirements for interventional radiologies. In fact, we have the cath lab and interventional radiologies room should be big enough to accomplish all the system. So at least 55 millimeters for standard interventional and up to 100 meters for the hybrid procedure room. And we have to ensure at least 1.5 meters a clearance area around the C-arm for smooth movement during the imaging. We have to consider using modular system for walls and storage units. This allows the flexibility for future upgrading. And also we have to take into account the robotic assisted procedure in IR, which are becoming more common nowadays and requiring additional space to accommodate its accessories. So from this point of view, larger rooms is better than a smaller one from the radiation protection field of view. For the shielding, of course, the shielding may be based on the report of NCRP report 147. We have to emphasize on workload because nowadays there is a huge number of patients and a variety of a procedure. This may increase in the future, so we have to put it in mind during a planning for the shielding and put the appropriate calculation using the worst case scenario. This will maybe benefit for us in the future. In fact, there's several shielding accessories in the cath labs and interventional units, radiology units. Looks like the lead curtains and the suspending ceiling lead shields. Also, portable lead barriers, mobile lead barriers. This is very interesting. What are the factors affecting patient doses. In fact, there are several factors which are affect patient doses. Let's see from now that staff doses and patient doses are linked, as the main source of staff doses is the scattered radiation from the patient. So when we reduce the patient doses, the staff doses will be reduced. All these factors can contribute to reduce the patient doses. First of all, fluoroscopy time. Fluoroscopy time is a very important. The radiologist may take it in mind to reduce the time of fluoroscopy. So less of time is better for the patient doses. This can be done also by the frame per second, reducing the fluoro frame per second from 30 frame per second up to 15, down to 15, or down to 3 frame per second can contribute to a lowest doses and may obtain also an acceptable image quality. So the high frame rate is not always necessary for all interventional procedure. The field of view also, decreasing the field of view by factor of 2 may increase the dose rate by factor of 4. So we have to take it into account. Patient sizes, the doses are related to the patient size. Thin patients receive less doses than the heavy patients, as we can see here. So for thin patient, 8 milligram per minute, and for heavy patient, perhaps it appears 10 times, which may appear to 70 milligram per minute. Take in mind that skin injury may appear after 2 gray in normal mode. The examination type and operation mode also. So we have to emphasize that the maximum distance between the X-ray tube and patient is the beneficial for the reduction of patient doses. And in the same way, minimizing the distance between the patient and the detector. So in addition to that, the anti-scatter grid, it's in fact enhance the image quality. It's reduce the noises, but it's increase in skin doses and patient doses. So increase, it should be removed for pediatric patient, for example. It's not necessary. Some examination may be complicated. We have to have some projection from several points. So the applicable projections also increase the skin doses and increase the probability of skin injury, as the length of radiation projection into the patient will be lengthier. We have to avoid the exposing the same area of skin in different projection. From the X-ray system, the performance of X-ray system is very important. We have to use the proper and a new system of IR, which comports, for example, for generator, constant potential and adjustable voltage, adjustable masses, several fixed angiographic currents, and so on. This is beneficial for reduction in the patient doses. Also, we have, let's take some highlighting the available protection tools. Here are the protection tools which are laid on the patient. There is a disposable drop which can put on patient, which keeps the scattering from the patient to be dispersing and affecting other parts of patient's body and also stuff. So we have reduction on body about 88%, and reduction on hands of on the interventionalist in about 82%. We can see the effect of these drops, which is lead-free and disposable. We can use it from one times, and it's very important, I think, in reduction of patient and staff in IR. In fact, the patient doses is related primarily on staff experience. If the radiologist is well trained, and can estimate how the procedure can be achieved in a limited and necessary number of images and frame rates, this will be an important cause in patient dose reduction and also staff dose reduction. So the correct indication, the fluoro time reduction, and so on, the sequences, the low frame rates, all of them can contribute to reduce the patient doses. The last one here is speaking about the height of table. In fact, for staff, short staff person can cause a short person will result in increase of patient doses and the person being closer for the X-ray tube. And this is because of the table will be lower. This may lead to increase in patient doses. From the factors affecting staff doses, in fact, the interventional physician receive more radiation doses than nuclear power plants worker per year on average. We have repeated small doses which contribute to a huge doses per year. This is from a survey done in USA in 2016. The staff and patient doses are, we said, it's partially linked. Scatter radiation is the main source of the occupational exposure, and it's not uniform around the patient. So the physician, nurses, radiographers, and so on are exposed to this scatter radiation, which may vary according to the role of every person inside the room, the proximity to the X-ray, and the protective measure used. This is the isodose curves for scatter radiation for typical operation condition and typical patient sizes. This is a well-known figure. Also, we have done a study in 2020 about the evaluation of radiation doses in different positions around the patient table during interventional cardiology projection for several IR system. We measured the doses in 8 points, and we noticed that some points have low or higher staff doses according to the normal position near the shielding plate here. One of the factors affecting staff doses is the patient size. It may lead to 10 to 50 millisievert during cine acquisition, as we are going from 16 to 24. This is the patient thicknesses. Also, there is an influence of operation modes. From low fluoroscopy to cine, scatter dose rate could increase a factor of 10. It's from 2 to 20 millisievert per hour for normal size. Also, the standing position, whether we are from the X-ray tube side or from the detector side. Scatter dose is higher at the X-ray tube side. When we have angulation of the gantry, the radiation protection involve the radiation protection of eyes, for example, may change when we are moving the gantry from left to right for low and raw projection. So we have very different scatter dose rated. What's important for staff is not the body or the effective doses for all the body, but for eyelids doses, which can be exposed to this scatter, and cataract can be appeared in some cases if the doses has exceeded the dosimetric the dose limits which have been specified later. We can use the lead goggles, which is very light and comport a lead equivalent of 0.75 millimeter from front and 0.5 from the side. This is very interesting. Also, the face shield, which comport 0.10 millimeter lead impregnated acrylic splash and can also contribute to face dose reduction. The lead apron is very essential for minimum for IR. The minimum thickness is about there is 0.35 millimeter pp. We can design it in wrap on type with 0.25 millimeter. So when we wrapped it, give 0.5 millimeter pp and protection. Typically attenuates more than 90% of X-ray. The fist skirt combination can distribute its weight onto hips and on the shoulders. This is very beneficial for women interventionalists. And also there is some aprons with light material which reduce the weight by over 23% and gives the same attenuation or protection or 0.5 millimeter pp, but it must be inspected fluoroscopically at least one time annually. In addition to the lead apron, we have to use the lead threshold shield with 0.5 millimeter pp, which attenuate about 98% from the direct beam. Also, we can use the gloves, lead gloves. There are several types of lead gloves which can reduce the hand exposure doses at the extremities. There is several types. One of them is disposable, lead-free, and can use for one times and can have some reduction in dose at the hands on extremity. Also, the lead cap, as we can see here. Nowadays, there is a new type of personal protective equipment, which is the ceiling suspended radiation protection systems. These systems carry the load of lead protective by this type of apparatus, so we can do the job without this heavy normal personal protective equipment. What's important with the PPE is the regular maintenance and the check for effectiveness. Defective equipment should be replaced to ensure staff remain adequately protected, and the annual inspection, as we said, is mandatory for that. In order to determine the personal or the occupational exposure of the staff, personal radiation monitor should be applied. We have the film pads, the TLDs or OSL. Either we can use the EPD, electronic personal dosimeter, for this task. But nowadays we have a new system which can electronic personal dosimeter, which shows in real time the staff doses, so we can alert the operator when radiation threshold are reached, promoting adjustment in positioning or shielding. And also the RBO can review the dose logs regularly to ensure the compliance with regulatory dose limits and identify trends that may indicate the need for further protective measures. In this types, this is a RaySafe i2 real-time radiation dosimeter. We can see the doses in real time for all the stuff inside the interventional rooms. This is a very interesting. As you know that in IR we use not one film badge, but two personal dosimeter, or perhaps 3 or 4, but 2 at least. We have one the first one is behind the lead apron, the second one is outside and above the apron at the neck level. Also, we can have a line doses and finger doses, dose meter, and we can calculate the effective dose from this equation for the radiation protection measure. Some typical IR doses in interventional radiology is unlikely to exceed 10 millisievert per year, more likely to have 2 to 4 millisievert per year. Per procedure, the neck above apron from 3 to 450 microsievert, the waist under apron up to 32 microsievert, and at hands fingers from 48 to 1280 microsievert. Some suggested action levels for staff doses as presented by the WHO IRSCE workshop, body 0.5 millisievert per month, eyes 5 millisievert per month, hand and extremities up to 15 millisievert per month. Now we are going to have some ideas about patient and the staff dose optimization technique. Optimization, as you know, doesn't mean minimization of dose to patient and the staff. Adequately diagnostically image quality should be assured during interventional radiology, which means optimize dose to patient and minimize dose to staff. So ALARA principle should be applied by optimization the equipment setting, using shielding, and ensuring staff are well trained in dose reduction techniques. In fact, we'll start this chapter with this slide, which comports the FDA recommendation for IR from 1994. Of course, we will speak about all these points, but I'm going to the last one, which is concerning the medical physicist. In fact, qualified medical physicist has an important role to assist in implementing all the optimization techniques in IR. This is to highlight the important role for medical physicists in diagnostic radiology and especially in interventional one. So we have to establish standard operating procedure, know the radiation doses rates for a specific fluoroscopic system, and assess the impact of each procedure protocol on the potential for radiation injury, modifying the protocols as appropriate to limit the cumulative absorbed dose, and use the equipment that aid in minimizing absorbed doses. So the key radiation protection strategy repose on ALARA, reinforcing ALARA principle and the staff training. Staff training is very important. It's the golden key to ensure the radiation protection inside the IR department. Continuous staff training is essential to ensure everyone understands how to implement dose reduction techniques and why minimizing exposure is very important. The ongoing education and radiation physics, safe practices, update its regulatory guidelines will ensure the staff remain competent in radiation safety, and also refresher courses and simulation can reinforce this concept. Regular quality control of IR system is the second radiation protection strategy in IR. It should be established and the staff should schedule these checks and provide sufficient room availability. It's aimed to minimize dose to patient and staff at the same time and optimize the image quality. Several quality control tests should be done regularly at the regular time, and some of them are very important to ensure that the machine is working in good manner. For example, if any if any faulty timer appear, can be lead for an extremely dose increasing for patient and the staff. So it's very important to check the X-ray tube performance, the dose measurement and exposure assessment, the image receptor performance, and so on. Also, we have to emphasize the role of a new technology in reducing the radiation burden, the AI-based dose optimization, and robotic assisted intervention, improved fluoroscopy technology. All of them can adjust the equipment setting to optimize those without sacrificing image quality, while robotic systems allow operators to distance themselves from radiation sources. This is an important, I had seen at the bibliography, Artificial Intelligence in Interventional Radiology, State of the Art. It's a new one published in May 2024. It's a contribute and highlights what's the importance of artificial intelligence in interventional radiology. Also, the artificial intelligence can play an important role in dose optimization, as a predictive model of patient and staff exposure can be included in this AI-powered models to adjust the protocol preemptively for patients who are at risk receiving higher doses. This predictive approach helps keep exposure as low as possible. Also, the patient dose recording is very important. Nowadays, with DICOM, we have the RDSR, which is the radiation dose structured report, which help with inpatient dose recording. It's important for this. These reports are important for dose editing and also for establishing the diagnostic reference levels. Here we can highlight the role of medical physicist to do his job by supervising and auditing the patient doses from these logs and doses logs. We have some new software for patient dose monitoring. Such of them are real time, so, as we said previously, which now we can see said about dose tracking, which interrogate those data and identify outliers. Several types of software now available from several brands, GE, Dose Watch, Sketra, Dose Track, Siemens, Timely Dose, Philips, and so on. Some software is capable of skin dose mapping also. Also, we have to optimize the imaging protocol. In fact, institution-specific protocols for various procedures as a tailored imaging protocols can significantly reduce radiation doses. Protocols should be optimized for patient demographics, pediatric with adult, and procedure type to minimize radiation without compromising diagnostic quality. Medical physicists here can play an important role and have a key role in the design and implementation of those reduction protocols that suggest adjustment in image parameters like frame rates, fluoroscopy duration, and radiation output levels. Some case study on effective protocol implementation can highlight how specific institutions have successfully reduced the radiation. So we have to focus on the case study, successful stories about radiation dose reduction in IR, present a specific case where a hospital has successfully implemented dose reduction strategies, such as upgrading to low dose imaging system or enhancing the staff training. This could involve reducing fluoroscopy time or optimizing protocols for high dose procedure like stent placement and other procedure. Also, we can take the lessons learned and define the best practices in this way. We can also introduce new imaging modalities in IR, like the robotic assisted procedure, which are available nowadays. And I think it will be the increased using this type of machines in the future. This system improves the precision and reduce the need for repeated images and consequently radiation doses. And we can reduce the staff doses as we can work with a farther distance from patient. This is the Maglin robotic system from 2016, and I see yesterday that Siemens has launched a next generation robot supported angiography system and takes the FDA clearance. Artist Fino. This is not a publicity for Siemens, of course, but I see that it's appeared yesterday during my preparation of this presentation. So we are going to use this type of imaging in the future. That's sure. Also, we have to develop the radiation safety culture in the clinical environment. We have to promoting awareness and compliance, fostering a safety culture involve ensuring that all staff members understand the importance of radiation protection. So radiation protection is not just a paper which we can put on the wall and ask the persons to read it and sweep it. Radiation protection is a culture. Radiation safety is a culture. So regular training session, safety briefings, open discussions about the radiation risks may help and encourage the compliance and vigilance. Here we can also the role of leadership and fostering safety. Leadership may play a pivotal role in establishing and maintaining a radiation safety culture. Hospital administrator and department heads also have their roles in this topic. We have also to manage the risk in IR. When we have some deterministic effects in IR, we have to apply the risk management policy, which involve in identifying the potential source of excessive radiation exposure, both for patient and the staff, and implements the controls to mitigate this risk. Of course, radiation-related risk may appear for prolonged fluoroscopy times, complex procedure, which is which we cannot we cannot take it away, and inadequate shielding or protection for staff and patient. This specific risk may include the skin injuries, but also can include also the stochastic effects like cancer for both patient and staff. The risk management includes the implementation of risk mitigating strategies like those monitoring software, adherence to ALARA principle, and ongoing staff training. And which is important here is the proactive risk management also. Pre-procedural planning to limit fluoroscopy time, using collimation, for example, and utilizing protective barriers effectively. Risk assessment tools should be used regularly to evaluate procedural risk, and patient also should be informed of the risk from the interventional X-ray procedure. The incident reporting and root cause analysis is very important. Incident reporting is an essential in any quality assurance program and should include the provision of records of incidents together with the investigation of the case and corrective action market. A root cause analysis should follow identifying the reason for the excess doses and proposing the corrective measure to prevent future occurrence. For concluding and future consideration, so we have to encourage a proactive approach to radiation safety in IR. Encouraging a safety-first mindset will ensure that both patient and staff safety are prioritized, especially as IR procedures continue to grow in number and in complexity. Radiation safety is an ongoing process that requires continuous vigilance, regular training, and adoption of new technologies. It's essential for all members of the healthcare team to take a proactive approach, regularly reviewing and improving safety protocols. What's the challenges in implementation radiation protection in IR? In fact, we have to admit that there is staff resistant to changes in workflow due to new safety protocols. It's normal to when we are introducing a new safety protocol, such as additional shielding or stricter limits on fluoroscopy times, may initially face a resistance from staff due to concern about procedure efficiency or workflow disruption. Overcoming these challenges requires clear communication about long-term benefits on radiation safety, leadership buy-in, and gradual implementation of changes. Engagement and education is a key, as we said, it's a gold key to getting staff on board with the new protocols and ensuring that they understand both the risk and radiation exposure and the practical steps to mitigate it. Sorry. So, as a final words, recap: IR imaging machine use ionizing radiation, which has deterministic and stochastic effects of human bodies. A good knowledge of IR equipment characteristics and the applied protocol are essential for an effective optimization of radiation protection. We have seen all the factors affected the education and continuous training in radiation protection in IR procedure for staff members are mandatory. Risk management involved is identifying the potential sources of excessive radiation exposure, and the medical physicists have an important role in optimization of patient and staff doses. Let's have some words about my organization, Atomic Energy Commission of Syria. I'm working at Health Physics Division, which belongs to the Protection and Safety Departments. We have several services provided in this division, like quality control laboratories for all diagnostic medical imaging and patient dosimetry laboratory, and we provide the personal radiation monitoring film patch and TLD, and support a diverse program of specialized training courses, seminars, workshops to train physicians, radiographers, medical physicists in the medical radiation protection. This is some slides. This is all in Arabic. We have a bulletin in radiation protection and some posters which are distributed in hospital in Arabic also. And the final word, thank you so much for your invitation, for your attention. I hope that this presentation may help you in your work. This is some photo from Damascus. Damascus is the oldest city in the world. This is the narrow rules in the old Damascus. You are all welcome in Syria and in Damascus. And thank you so much for Dr. Sadiq for this invitation. Thank you so much. If you have any question, I'm ready to discuss with you on the points. Thank you.
Thank you, Dr. Lahfi, for this very comprehensive presentation. Any questions from the audience? We have one first question from Dr. Duhaini. What kind of data would be used to train an AI algorithm in AR?
In fact, there is several data can be used for training the AI coaches in AI algorithms. We have the patients, from the patient himself. We have the thickness of patients. We have the weight of patients. We have also the SID. We have the kilovolts, we have the milliamperes, we have the frame rates. All of them can be contribute to learn the AI algorithm to arrive to the suitable and is not suitable. This proposing the let's say the perfect or the proper control like kilovolt and so on. There are several nowadays we can see on bibliography. We have several studies in this way. Such of them are not arrived to obtain the FDA, so we can use it and incorporate it with this machine. But I think with the AI, with AI now, you know, the AI is going increasing nowadays. And I think no later than 2-3 years we can have all this technique and algorithm incorporated in our IR system. I didn't work in really in my research in developing AI algorithm for reducing patient doses, but as I read in bibliography, I think I saw many papers which use these parameters to learn the AI models.
I have a question regarding the use of robots in IR.
Yeah.
You mentioned that it reduces the dose to the staff, which is kind of, obvious, output. But how efficient you think robotics is in reducing the dose to the patient? Does it help performing the IR procedure more efficiently than an interventional radiologist doing it manually by hand?
I think with the robotic arm assisted system, the efficiency of a procedure may be enhanced. So the time, fluoroscopy time may be reduced, and this will be reflected positively on doses. Because as you know, when the interventionalist ride the robotic, we are riding the robotic. It's not, the robotic doesn't do the job from itself. So the interventionalist use the robotic as a precise arm to do the procedure. And in this way, I think we can gain some time, and this will be reflect positively on the patient doses. As we mentioned in the presentation, in fact, we have the larger distance from patient. This incorporates a very staff reduction for the staff doses. So we have an important reducing in doses for the staff as we are working from a further distance from the patient or from the X-ray tube.
Any other questions from the audience?
Yes.
All right.
Okay.
If not, If not, we'll conclude here. And there is two questions regarding, it's an IT question. Where can we find the recording for the lecture?
Okay.
Is everyone, everyone, I'm going to send you my email. Please email me and I'll reply with the link.
Okay. I think in the future we will see a very important advancement in IR. not only the artificial intelligence algorithm and image processing, but the robotics which are coming in this domain will maybe let us see a new organization of the IR department. As I said yesterday, with this type of robotics proposed by Siemens, for example, it's a new, let's say, a new age of IR. We are coming to a new area of IR, and this will be reflect positively for patient doses and for the staff doses. Very great advancement in this way. As conclusion.
We have one more question. Is it recommended to wear the lead gloves during the IR procedure?
Of course. Of course, it's very important to have all the protective and shielding materials which we have in our IR room. So the lead apron, the goggles, and the teroid shield. This is very important to keep using it. I know that I had many studies in IR for patient dosimetry, and I know that it's very hard to put it for half an hour with its weight of about 20 kilos or 23 kilos. It's sometimes difficult, but we don't have a choice. We have to protect ourselves.
Can you comment? Some of the IR procedures incorporate PET imaging. So injecting the patient with radio tracer, do the IR procedure and then do QA, or have PET guided IR. So all these techniques do not shield from the 511 keV photons from the PET radio tracer.
Yeah.
Do you have any recommendations on how to reduce the exposure to the staff? I mean,
in fact, when we use radio tracers or FDG, like example, with a very high photon energies, the shieldings becomes the efficiency of protective shielding becomes very very low. So we have to consider the other radiation protection principles. The distances we have maybe have a longer distances from patients during the procedure as possible as we can, and we have to in the same time maybe enforce the shielding, suspending ceiling shielding with a larger one, and work in this way to have more shielding from patients. But really, it's a very difficult with nuclear medicine and PET intervention when using FDG, for example.
Okay. All right. So if no more questions, I would like to thank you again, Dr. Lahfi, in the name of the MIFOMP organization. And thank you so much for your attendance. Hope to see you all next month.
Thank you so much for your invitation again. Thank you, Doctor.
Thank you.
Thank you for all the. Thank you. Bye-bye.
Bye-bye.